Hello, and welcome to Capital Compass. We are the official podcast of the New York State Catholic Conference. I'm your host, Gillian. Today's episode is being released outside of our normal posting schedule because of the urgency of this topic. There are 2 more weeks in the 2024 legislative session, and sponsors of the physician-assisted suicide bill are making a full court press to get the bill on the floor for a vote. Joining me in episode 39 is Max Rodriguez, Manager of Government Affairs for the Center for Disability Rights, to discuss the dangers of physician-assisted suicide legislation and why everyone should be concerned about it. Joining us on the show today is Max Rodriguez, Manager of Government Affairs for the Center for Disability Rights. The Center for Disability Rights advocates for the full integration, independence, and civil rights of people with disabilities. Welcome to the show.
Gillian, thanks for having me.
Now, we have covered assisted suicide on this podcast previously, but it involves multifaceted legislation that could affect all New Yorkers. So to start, can you tell our listeners why physician-assisted suicide is something everyone should be worried about, not just those who are concerned because of their religious principles?
Yeah, absolutely. So the proponents of the current legislation would have you believe that, this is targeted towards a very narrow, specific portion of the population. So typically what you will see in states and other countries who have legalized similar laws is you'll see an expansion of who is eligible to receive assisted suicide, or what you will see is the wait list shortened. A lot of times, initially these laws will have, a certain, parameter of 2 weeks or, some allowed or some amount of time to where you can, receive the procedure. And oftentimes what you'll see is once these laws are enacted, those change fairly quickly.
Access to assisted suicide is often discussed as a solution to quote-unquote poor quality of life. What does it mean for the disabilities community to hear loss of autonomy, mobility, etc. equated to poor quality of life, and that such a life is not worth living, or those individuals don't deserve the resources to keep living?
Frankly, it's just offensive. The idea that anyone who might need assistance, eating, getting out of bed, bathing, things like that, basic, life, daily events, activities that you might have to do from day to day, and the idea that somehow if you need assistance with those, you somehow become a burden or you're unable to live a full quality life is actually just really sad.
Why would the legalization of physician-assisted suicide degrade rights for marginalized groups and individuals facing discrimination?
So unfortunately, what you see often today is disparities in healthcare between, people who are financially well off versus people who may not be. Often you see healthcare disparities in black and brown neighborhoods, minority and ethnic communities. And unfortunately, so what you'll see is people who don't have access to quality healthcare may not have access to services, like I said, those daily activities that people may need, people, who can't afford personal care aids, things like that, might, end up in a situation where they might be feeling hopeless, or they may be feeling like they're in a situation where they can't go on receiving treatment, especially prolonged treatment, treatment that might, render them unable to do certain things. And that's really where you'll see those rights degrade, because people do have the right to live. They do have the right to, pursue care. But unfortunately, if you feel like you're unable to, this will present an obstacle to that, because, you might have a physician or, even a family member or a caregiver, unfortunately, saying, maybe prolonging, your care is not the best option.
Now, I feel like we see this a lot, but legislators who are in favor of a physician-assisted suicide kind of have been misleading us with the language of this bill. Can you explain to our listeners how so?
Yeah, so, I don't necessarily think it's intentional in misleading us. It is very clear that many proponents of the bill, especially legislators, have not read the bill. or they're confused on exactly what the end result of the legislation would be. Um, a lot of times it goes back to things like they'll say that there's certain guidelines, there's certain safety guards in place, and that's not really true. One of the big ones is mental health.
Could somebody request assisted suicide because of depression or other mental health impairments?
So this is where it gets difficult. So to answer your question is, it is possible that that happens because there's no screening to make sure that people are mentally sound. In theory, it would not happen. However, it's really hard to verify, again, because there's not screening for mental health. The way it's written is that if your doctor thinks there could be underlying health issues, mental health issues, they could, reject you for assisted suicide. However, that's not proactively wondering if there could be underlying health issues involved.
Have we seen mental health issues with other states in terms of physician assisted suicide?
Unfortunately, it's not something they really track for. That kind of goes, to the heart of a lot of the issues with this legislation is there's almost no reporting, and the very little reporting that is actually done is either skewed or it's either skewed or what they're reporting doesn't actually point to some of those issues.
So, on another hand, you see a lot of people who are, I guess, older thinking about physician assisted suicide. Could patients feel compelled to request it if they're being abused or if they feel like they're a burden to their families?
Yeah, absolutely. I mean, the people that this legislation is targeted to, by default, are some of the most vulnerable. So, what you do see in aging populations and the disabled community is higher than average rates of abuse. And that's for a lot of reasons. And unfortunately, what a lot of times what that will boil down to is that it's actually coming from caregivers and family, whether that be physical abuse or financial abuse, emotional abuse. There's a variety of different ways we see that manifested. And a lot of times, what it is, it's not, especially when it comes to verbal cues. I think there's a misconception that the only type of abuse that you would see in this case is, a caregiver coming up to somebody and say, "Hey, you have to do this," and that's truthfully that's just unlikely. But what you will see, and what we have heard in other places, is it's really certain comments over time that kind of build up, almost in a soft pressure sort of way. Things of, "Hey, mom, it's getting really hard to bring you to these doctor meetings every week," or, "Hey, dad, you know I'm taking a lot of time off work for this. Like, what can we do? Are there other people?" And essentially what you'll see is over a period of time that really starts to take a toll on somebody's like mental stability and psyche, and then they're left feeling like they're a burden to those around them, and that it's unfair to their caregivers, and unfortunately what we'll see is you'll start to see a mental degradation, and the person might more likely consider this than if
Yep. We've also seen, like in Canada, people talking about um, wanting physician assisted suicide because it's essentially cheaper for them. What's your stance on that?
Yeah, and it's really just too bad. It's too bad that we live in a world where it's easier for insurance companies to deny care to somebody and just say, "Hey, it's going to cost us $1 million to treat you, and maybe there's only a 50% chance that you live, and then here's this option for assisted suicide. It'll cost us a fraction of the cost, and we're just going to speed up what's inevitable for you anyway." And then you bring up Canada, and this goes back to the expansion issue. In Canada, you see that often people go to their doctors and they request medical care, and what they're in turn met with is, hey, assisted suicide's a better option for this. There's cases of, disabled people requesting grant money for, home modifications such as ramps, and being denied for that, and then all of a sudden receiving a phone call 2 weeks later from a hospital saying, hey, we think you might be a candidate for assisted suicide, which we might think is a huge jump, but these are documented cases that are happening in places where this is legalized and unfortunately normalized.
We're worried about the slippery slope, but also if you look at under this, the way the bill is currently written, no witnesses are required when death occurs. So for victims of elder abuse and for people with disabilities, this kind of sounds dangerous. What do you think?
Yeah, absolutely. I mean, it's one of those things where, take a situation where somebody might not be in a good headspace and they think they want to go through with this procedure. So they go and, the doctor writes them a lethal prescription. They bring it home and then, they have a change of heart. They decide, they wake up one morning and they would decide, what? I gave in a moment of weakness. I want to fight this thing. I want to continue to keep going. But at that point, the lethal prescription, it's written, it's at home. And because there's no requirement for a witness to be present, maybe there's a, caregiver or somebody who, is kind of, done with what they're doing and they kind of want to see this process end. And, unbeknownst to the person, they administer it to them with, against their will without their knowledge. There's no way to verify any of that. In Oregon, a quarter of the lethal prescriptions that have been written have an unverified diagnosis status, which means the state has no idea what has happened to a quarter of those lethal prescriptions. And I think that's pretty alarming.
It also just begs the question of where they went. Our last episode was dealing with the opioid epidemic, and it's kind of like, this is a known full lethal drug, like somewhere where the government has no idea where it is.
Yeah, absolutely. And, you think about this in other aspects. What if somebody got a hold of that? What if there was somebody else in the house that had a mental health issue, had a dependency issue, was suicidal in one way or another, and got a hold of that, prescription? I think that leaves I think that leaves the door open to, kind of figure out who's liable in that situation. What are the repercussions, both legal, personally, and as a society, how do we grapple with that? If you're in a house and, a 15-year-old goes into their parents' refrigerator and grabs a beer, that's on the parent. If that was to happen in this case, is that on, this, sick person who, could potentially, may not actually be controlling their own medications?
Now, some might argue that this bill will only apply to a small number of people. Why do we have to worry about, we were talking about expansions. Why do we really have to worry about this and all the amendments of this legislation?
I think that's a good point. Often, unfortunately, people think of terms in how will this impact me? And for a large portion of the population, they would say, at this time, this doesn't impact me. Or, somebody I love or somebody I know. But what you will see is over time, it will impact you at some point. It will impact a loved one. It will impact someone you know. So, as this law, if this law is passed, again, we talked about, the expansion to people with mental health issues, people with, mobility issues, generally disabled people. That will ultimately, intersect with your life in one way or another. So instead of saying, this doesn't impact me now, it's fine, I think what we should do is say, look at when it is, expanded to the full extent that people want it. Um, how will it impact me then? Is this something I'm really comfortable with? It's easy to look at it, in an aeroscope and say that's fine. But realizing the ultimate goal for a lot of people when it comes to this legislation, I think that's important.
A previous podcast episode, we also had a doctor from Canada talking about the dangers and again how this could impact us. What can we, domestically, what can we learn from other states, and then also internationally, what can we learn about other countries that have already legalized this horrible act? I mean, the Netherlands has had it legalized for almost a decade or over a decade
Over a decade.
by now.
Yep.
Yeah.
Truthfully, I think what we can learn is that we shouldn't legalize it. In Canada, there was recently a provision that was shot down for the second time about expanding it to people with mental health issues. That goes beyond the most severe mental health issues. Actually, can you cut that? And that ranges anything from, schizophrenia to something like anorexia. There's a lot of issues that, people might not be aware of that could potentially, intersect with this. Or in the Netherlands, where you have people, who are, encouraged to, opt for the procedure who might be artistic, and that's really scary to me to think that, you know, people with these medical conditions or, the way they were born, could potentially, be viewed as living lives that are not worthy.
Yeah, it's kind of getting into the scary part of like eugenics almost.
No, it absolutely is. It absolutely is. Because what you start to see in a lot of these places, especially in some of these European countries, is, it really comes down to is who gets to decide who lives a life worth living. I think we've seen that played out in a few eras of history, and I don't think anybody really wants to return to that.
Absolutely not. Now, this is meant for people with terminal illnesses, but how accurate are those diagnoses? And, what if the patient could have more time to live?
Yeah, I mean, that's a great point. I think everyone knows at least one person, that was given, a certain amount of time, and then they live, 2, 3, 5, 10 times as long. People sometimes are given a year and then they live for 10. Some people are given 6 months and then they live for 15. These aren't unheard of situations. So I think that's something important to keep in mind. The other issue is a lot of times prognoses and diagnoses are not exact. If you get, if you go to your doctor on January 1st and the doctor says, we think you have 6 months to live, that doesn't mean you're going to die on June 1st. There is quite a bit of
Interpretation.
Interpretation, yeah. These things are not set in stone.
Yes.
So I think that's important. Then the other issue is, a lot of times it's a matter of opinion. One doctor might think you have 6 months, another doctor might think you have a year. And if that's the case, then really, like, how do we decide who is more accurate? Does one override the other? A lot of this is left unknown.
Now, the healthcare system doesn't always have the patient's best interest in mind. Uh, long-term healthcare can be expensive. While it's only a one-time cost for life-ending medication, does this issue of cost factor into decisions by doctors or patients to pursue assisted suicide? How can we prevent this?
Yeah, absolutely. I mean, I think it does. It would be naive to, sit here and think that insurance companies don't think about, how much do they, spend on, cost of care. This is certainly a cheaper option for a lot of insurance companies. And it's a cheaper option, throughout the healthcare system, unfortunately. However, I don't want to live in a society where we do things just because they're cheap. I want to live in a society where, quality of care is important, that we're making sure that people are living their best lives to the best of their abilities. And that's really why we should focus on things such as, community-based services, home care services, palliative and hospice services. I think that's really important. The other thing is that we should focus on healing. We should be focusing on advancing, medical treatments and drug therapies and things like that. This is really, at the end of the day, to kind of put it bluntly, this is really just kind of taking the easy way out as far as healthcare goes, and that's unfortunate.
Now, for those interested in learning more about the Center for Disability Rights or want to get involved, how can they find you guys?
Sure, you can go to our website, www.cdrnys.org. And you can go to our website or our social media page. We have a Facebook page. We have a Twitter and Instagram. We have all the social medias. So,
All right. Thank you so much.
thank you.
Thanks for listening to the Capital Compass podcast, and thank you so much to Max for coming on the show. We hope you enjoyed this episode. We'll be coming out with a new episode the last Wednesday of each month. If you'd like to support the podcast, please share it with others, post about it on social media, or leave a rating and review. Don't forget to subscribe wherever you get your podcasts. And to catch all the latest from the conference, you can follow us on Instagram and X, formerly known as Twitter, at NYS Catholic Conf, and on Facebook at NYS Catholic Conference. Thanks again, and God bless.